older women think it's just part of getting older. You look in the supermarket, all those incontinence pads. It's kind of normalised that women will leak. No, let's not put up with this, because there are things that can be done to help.
Hi, I'm Jo Clark, and thanks so much for joining me today. This is the Redefining Midlife podcast, a podcast designed for the 40-plus woman who is determined to challenge society's myths and beliefs around midlife. It's for the woman who is inspired and ready to define midlife her way. Join me each week as I chat to health and wellness experts for up-to-date information on how to live well as some special conversations with incredible everyday women redefining what midlife can look like. Here's to making our next half of life even better than the first. Welcome to episode 105 of the Redefining Midlife podcast. Today, our very special guest is a wonderful Dr. Sian Hebron. Dr. Hebron is a specialist general practitioner with over 2 decades of experience, with a special focus on menopause and women's health. She's a graduate of the Royal Free Hospital School of Medicine in London, which was the first medical school established for women, before she made her home in Australia in 1992. Dr. Hebron initially worked in hospitals in New South Wales and Queensland, and she completed her specialist GP training in 2000. She is a member of the Australasian Menopause Society, which reflects her commitment to supporting women through all stages of midlife. Beyond her professional life, Dr. Hebron is a proud mother of 2 daughters. She is passionate about maintaining a healthy lifestyle, fostering curiosity, and exploring the wonders of the world. Her love of adventure and staying active inspires both her practice and her personal life, embodying the belief that life's journey is best embraced with vitality and a sense of wonder. I can honestly say that Dr. Sian Hebron is the doctor that every woman would love to have in her corner. This really is a must-listen episode for all women, because we're talking about some big, juicy topics that all women should hear, including everything from sexual health, the effects that alcohol has on our midlife body, and then the recent focus on what some would say is the over-medicalisation of menopause. Now, towards the end of our chat, Dr. Sian also answers a number of questions that have come from both my community of women on Instagram, as well as from the community of a past guest of mine and new friend, Bev Williams-Krause. Now, the information in this special episode empowers us to make decisions that are right for us. And we know that getting accurate health information these days really isn't so easy with everything's on the internet. So, as always, if you think that this episode would help someone else, a girlfriend, sister, or colleague, make sure that you share this episode with them. Enjoy. A very big welcome to the Redefining Midlife podcast, Dr. Sian.
Hello, Jo. Thank you for having me here on your podcast. I'm very happy to be with you.
Well, I'm really happy that you said yes to coming on, because today we're going to cover topics that are super important for women's health in midlife and beyond. So everything from sexual health, the effects of alcohol and what it has on our midlife body, the recent focus on what some say is the over-medicalisation of menopause, as well as a number of questions that have come from my community of women on Instagram, as well as a community of my gorgeous friend and your patient, Bev Williams-Krause, who, by the way, has also been a guest on the podcast.
Yes, lovely Bev. Thank you. I'm very pleased that she chatted to you about me, and as you say, it's about getting that information out, as you do on your podcast, to help women at this time of their lives, which is a very exciting time, I think, too.
It is a very exciting time, and the more information we've got, the more empowered we are to make the right decisions for ourselves. So thank you for coming on. Now, although you're based on the beautiful sunny coast, which is lucky for, say, the likes of Bev and I, your accent tells us that you weren't born in Australia. So would you like to share a little bit about your past history, where you came from, your career path, and what brought you to Australia?
Okay, well, I come from the southwest of England, and I trained as a doctor in the 80s in London. And it was a difficult time back there. We had very long work hours, and I was complaining to a doctor. I was training in pediatrics at the time, and I was complaining to an Australian doctor about how awful our weather was, and he said, "You need to go to Australia." So I did. I came over and worked in paediatrics in Sydney, and met my former husband, and and decided to stay because I think Australia's a beautiful country, lots of opportunities. It's been very good to me. I pivoted away from paediatrics because I wanted to have my own family, and made a great decision to enter general practice, which I've thoroughly enjoyed. One of the reasons I've come into this field in helping women through their hormone challenges was inspired a bit by my mum and her mum, who both had very difficult menopause times. My grandmother had to have radiation treatment for heavy menstrual bleeding. Back in the days, that's what they did to help women who were bleeding. And my mum had usually a very, is still at 92, an amazing, vivacious, happy, curious woman who became, practically suicidal through menopause. So, when I came into general practice and I saw women who were struggling, I could understand because I'd seen my own mother go through that. So, yeah, and I've always embraced women's health as a female GP. It's important, I think, to be able to talk to other women about their health.
And just explain what the difference is between, say, a woman coming to see you as a women's health specialist, menopause specialist, and just seeing your GP. Like, how do you create a different sort of an experience for a woman?
Yes, I think we have to be, mindful about the language we use, because, I am a GP. We're all GP specialists, but my focus is on women's health. And what I have done is, attended forums, conferences, I've done research, read my own papers, dug around, so I can get as much information as I can to share with the women who come to see me. Not all GPs have that interest, where they have different areas of passion. You'll get GPs who love sports medicine or skin or mental health, but this is my particular focus. And what I've done is sort of etch out in my day time that I can spend with women, rather than 15-minute appointments, which we all know doctors' appointment books tend to run on. I carve out an hour to give to women so I can really look at them holistically, look at all of their background, not just their hormone journey, but also their other physical health, what their habits are as far as alcohol, eating, their relationships, because all of this is really important when you're trying to help a woman go through that midlife transition time, which is hormonal, yes, but it's also a lot to do with their life, their changes in their life, the kids getting older, their parents getting older, whether their relationship is still working. So it's all of it is important. So I suppose that's the difference that I am providing, is that time and that interest and focus. Yeah.
And that's something that a lot of women would never have experienced in a doctor-patient relationship before. So that would be reassuring, I imagine, for a lot of women.
Well, I think it's also, for me, it's very rewarding because, so often women don't get heard. This is also in our society. Women don't use their voice. We're not taught to. We're not taught to complain or to speak our truth. It's not been seen societally. I think it's changing for the younger generations, I hope. But definitely when we went through our childhood and adolescence, it was, sit still, smile and look pretty. You definitely didn't say you had a bad period. Good Lord, they were not to be mentioned, were they? So I think it's a lot about being listened to, and to allow a woman to share and have their opinion about what's going on, and for me to sit and listen and say, well, what do you think is happening, and how do you think you'd like this to work for you in the future? I think a lot of doctors, and I'm sure I've been guilty of this, tend to talk at people. and tell them what we know to be right. And I think that's something that we as doctors need to really learn to not do that and to listen more.
Mm. And for some women, they mightn't be able to say what's exactly wrong with their body, but they know something's off. And by having somebody ask some questions, it's putting those pieces of the puzzle together. That's so important.
You know, Jo, one of the main things that women will come and tell me is, I just don't feel like me anymore. You know? And that's a horrible feeling. And I don't know if you experienced that when you were going through transition and menopause, but I certainly did. I thought I was a lunatic. I think my children probably did too. You know, so, you know, it's a horrible feeling when you lose that sense of self and identity, which can definitely happen and really scare us at this time.
Oh, I can still feel, I'm still going through the transition, Sian. I'm 56 and a half, and 56 and nearly 8 months, still going through the transition, God love me.
Oh, I feel for
so
you.
it's ongoing. I'm sympathizing with many, many women right now.
Yes.
Well, we might get started on the topics that we decided to discuss on for this podcast. So firstly, alcohol. What are some of the specific health risks that are associated with alcohol during midlife for women, particularly in relation to menopause?
I think, you know, as we get older and go through menopause, we know that we're less tolerant of the effects of alcohol. You know, part of that is, you know, part of the natural aging process, and also because of the hormone, the fluctuations in our estrogen, progesterone, testosterone definitely have an impact. I think also as we put on weight, we do know that affects our metabolism of alcohol. So our blood alcohol levels can rise, you know, quicker than they used to and stay higher for longer. So, you know, whereas before we might be able to, you know, drink, I don't know, 2 or 3 glasses of wine without feeling too tipsy, now we can't. They also, you know, potentiate those vasomotor symptoms, make them worse. So often women will say, oh, I used to be able to enjoy red wine. Now, as soon as I have a wine, I flush. And you go, well, yeah, that's one of the, you know, tells of menopause. I think, you know, alcohol is very interesting, isn't it? Because it is a toxin. It is a cancer-causing chemical. It does cause a lot of problems in our society and in women's life as well. Yeah, it's legal, and culturally it's a norm. You know, we go out, we drink, we socialize, we have a few drinks to let our hair down. But, you know, a lot of us don't realize how dangerous alcohol actually is as a toxin. And, you know, yes, we get hangovers and we get a headache and we lose some hours of productivity, but also it can increase our risk of breast cancer. And I think, you know, women are obviously, we're all very scared of, you know, will that happen to us? We all have friends, many friends, some of us, who've had breast cancer. And it's one of the reasons why women got put off hormone treatment for their menopause, obviously. But, you know, alcohol is one of the big risk factors for breast cancer. And I think a lot of women don't actually understand that. And you don't have to drink a lot for that increased risk to actually happen. You know, 2 or 3 glasses of wine a week will give you a 5% increase in your risk of breast cancer over and above the background risk, which is, you know, I think it's now the stats are something like 9 in 100 of us will get breast cancer. So, you know, if you have alcohol every day, you're going to increase that risk to 10%. If you have more than the safe limits of alcohol, which is 10 standard drinks, which is a teeny tiny glass of wine, then you're going to go up to 15%. And you know, and I think we need to let women know it's not an innocent thing that we take in. Alcohol can be very detrimental to our health and well-being.
Yeah, there's a lot to unpack in what you just said there. So thinking about my own experience, my relationship has changed quite a lot with alcohol, and it had to, because I would, not that I was a massive drinker, but I would have half the amount of alcohol of what I would normally have and get twice as unwell. It wouldn't take much to make me feel the effects of it. You know, waking up in the middle of night, heart racing, just feeling revolting the next day. And I go, oh, but I might have only had 2 or 3 glasses. It wasn't a huge amount. It wasn't a binge. I didn't down a bottle of wine, but yet I would feel those effects to the point now where I just, is it does your body start, this, I don't know if you can answer this question, but does your body just start to innately go, it's not good for you?
Well, I think
Off.
so. With age does come wisdom. So maybe nowadays when we feel a little bit unwell, we go, "Oh, I really shouldn't do that." Whereas back when we were in our 20s, we just go, "Oh, I can get over it. Just go for a run."
Yeah, like a goldfish. I've forgotten what that was like.
Yeah, but no, physiologically our bodies do change. You know, with the changes in the hormone levels and the fat distribution. Yes, our bodies do change, and we do feel the effects of alcohol. More so as we get older, and also you know, a lot of women are on medications that they may not realize interact with alcohol. You know, some of the antidepressant medications definitely can increase your susceptibility to the effects of alcohol, and you know, I don't think a lot of women are maybe even told that. You know, it says on the packet, don't drink alcohol, but you know, we're all a bit, you know, we like a bit of risk in our life, so we may not really take that on board and say, oh, well, a couple of glasses won't matter. Well, they do. You will feel the effect.
Drink, Sian, like, I think we don't realise what the standard drink amount is in a glass of wine. That's right. So perhaps it's drinking more than what that standard drink is, and that can that can get you into trouble.
Absolutely. And you know, I think, you know, obviously when you go out to drink at a restaurant, they pour you a standard glass, but some don't, depending on the restaurant, and sometimes they ask you, do you want a larger glass? But at home, who measures 100 mils of wine out? And we all like these lovely big glasses, don't we?
Oh God, yeah.
They you know, they give you the swoosh and the aroma of the wine.
And I remember in the early 2000s, they were almost like half a bottle of wine per glass. And you go, dear God.
Yeah, literally.
Yes, I had a friend who would just slosh around one of those and put a couple of ice cubes in. Just
yeah, and of course, you know, remembering that, you know, wine that has that's carbonated, like your fizz, champagne, prosecco, you absorb that very quickly because of the bubble increases the surface area. So you will feel the effects of a glass of champagne more quickly. A lot of women drink quickly. We get thirsty. We might be a bit dehydrated. So we go out for a wine, we have the ice, we drink it quickly. We have another one, we drink it quickly. It's very easy to drink more than you realise. Yeah. So I think anyone listening here, I hate being the fun police, you know, but I think we all do need to take stock and realise that it is a toxin, it is a cancer chemical. We do need to enjoy ourselves and our lives, but very much in moderation, because as we get older, our risks of these problems increases with our age anyway. So why would we want to do something that's going to add extra risk on top of that, you know? So I know your listeners are all wanting to do their best health-wise. So let's encourage all of us to, you know, just be mindful of what we're drinking and how much we're drinking and when. There's a culture, I think, also, you know, in our society that we meet for drinks. Yeah, so, you know, maybe we're in our group of friendships, we say, oh, okay, let's meet for a walk, or let's do something active, just change it around a little bit. I know I have some patients, some women who have had to stop drinking because, you know, they've had a health scare. One of the things that can happen when we drink a lot over a period of time, it can affect the nerves in our feet and in our brains, so we can get pain. And, you know, sometimes if you're the one in a group of friends who says, well, actually, I'm not drinking anymore, you get this peer pressure. You know, I've heard it.
Oh, yes, so have I.
You know, oh, you're no fun. Oh, have a drink, just one. You know, just come on, jolly up, have a drink. And it's not fair. We need to support women who say that they don't want to drink anymore. They've probably got very good reasons for it.
The societal pressures to actually drink, and we drink for various reasons. You know, you mentioned, we'll meet for a drink after work, or we'll drink to celebrate, we'll drink to commiserate. It's attached, it's so endemic in our society and in our culture. It is really hard for to find that break and to be able to be strong, to say, look, I'm just not going to. So again, the importance of the people who are around you, we can't underestimate that.
We can't. We've got to find that inner network of people who support us. And you have people who don't want to be your friend anymore because you're not drinking. And I've heard that too. Well, then it's time to let them go.
Yes.
To let them go. I mean, really, when you think about it, we are so heavy on tobacco, aren't we? And we never say to each other, let's meet after work for a cigarette, but it's really, it's a health hazard as high as smoking. When you think it's linked to bowel cancer, breast cancer, esophageal cancer, Alzheimer's, nerve problems, muscle problems. Yeah.
Well, that's it. It's being informed. And again, thank you for raising all the other effects that can happen to you, side effects that can happen if you consume too much alcohol. Because it is as you said, it is a poison, and nobody actually sits down. I know we have to be, find out information for ourselves, but sometimes it's not easy to come across, and maybe we don't want to hear it. Maybe it's the news that we don't want to hear, but again, we need to be empowered by this information.
We do. And we also need to remember that we're not saying, people have a problem with drinking, or that you're an alcoholic, or you're alcohol dependent. It's actually not that much alcohol that causes harm. And they recently brought out, in 2020, there was a consensus statement, I think it was a world consensus statement, on what is safe limits of alcohol. And really, the safe limit of alcohol is 0. America said 7 standard drinks, not very many at all. Australia compromised at 10.
Of course they did. Yep.
Yeah. So it's not a lot before you can start getting adverse effects from alcohol. Yeah. And that's not going into the the risks that we have if we binge drink. You go out, you have 4 to 8 to 10 drinks. The risks involved in women's safety, taken advantage of, blackouts, falls, problems driving, etc., etc. This is just your regular, I'll just have a glass of wine when I get home from work. We're talking about that kind of what we would consider normal behavior, but without really realizing you could be causing yourself some harm forwards.
And we do know that mood can be affected during the menopause years as well. So what's the effect on alcohol and mood? Is there any correlation there that we've got, that it increases your risk as for women who are in this age group?
Yeah, I think, we do know that when we're in transition and menopause symptoms, some women are very badly affected by mood, anxiety, depression. What do a lot of women do when they feel like that? They try and have a drink to relax. Yeah. But alcohol, we know, is a depressant. So if you drink, say you have a couple of wines, the next morning you're actually going to feel worse. Not hungover, but your mood will drop, and your anxiety symptoms, heart racing, irritability will go up. And that's in a small amount of alcohol that you wouldn't even think that you were drunk or tipsy or anything. But it, over a period of time, can definitely bring your mood down and increase your anxiety. But it is often something that women will turn to self-medicate to help them feel better. So you get caught in this catch-22 situation. So, a GP needs to ask women when they're seeing them for whatever reason, if it's not, part of their routine questioning, we need to do that. How many do you drink every day? How many drinks would you have? Is it a standard drink, like 100 mils, or is it a home pour? And try and get an idea, because we do know that alcohol does affect mood and make it worse.
Yeah, no, that's good information for people to make an informed decision what's going to be best for them. Because as you said, you don't want to be the fun police. No one's saying you can't drink or you shouldn't drink. It's just that with this information, you make the decision for yourself.
Drinking in safe limits as much as possible. Do the best you can. Yeah.
Great advice. So now let's move on to the topic of GSM, which is a genitourinary symptom of menopause. Now, in a syndrome of menopause.
Mm-hmm.
Not
I
symptoms.
know they're big words, aren't they? But they're much nicer than the
Hey, it's a
previous.
mouthful. It's a mouthful. But in the past, it has been called a vaginal atrophy. And I've also heard the term before that was called a geriatric vagina. Dear God. That's just.
Oh,
So I'm
oh,
assuming those
nasty.
labels were were horrendous and may have been actually created by a man. I won't say it definitely, but I've got a fairly
Yeah,
high assumption that that would have been the case. But anyway,
yes,
just saying it's affecting the vagina doesn't take into consideration all of the wide range of symptoms that a woman might experience during
yes,
these years and beyond, because it's
yes,
something that they may not have, at the initial stages of perimenopause and menopause, but it might be something later in a woman's life that these symptoms occur. I
absolutely.
had on episode 85, I had Dr. Neve Leonard, who was also a GP who specialises in women's health. She talked a little bit about that topic, but some listeners mightn't have heard that episode. And plus,
Okay.
we need to know more. We need to hear this information again and perhaps build
Yes,
on it and hear it in a different way.
yes. I think you know, women. We've on the whole, women are quite shy creatures. We don't discuss our vaginal bits very often, if at all, to each other. And I think it's really important that we open up to each other, talk about this and talk about this with our GPs and get comfortable with what our vulvas, vaginas look like and how they should feel. Yeah.
Yes.
Remembering that there are estrogen and testosterone receptors all around the vulva, clitoral area. So the outside lips, the inside lips, the vagina, and around the clitoris. Yeah.
Yes.
So when we go through menopause, when all those hormones are going down, these tissues aren't getting those lovely messages from the hormones. And what happens is they change. We get a change in the collagen, which is the plumpness. We get a change in the surface, so we don't produce so much mucus, and the tissues can start to shrink down, and the clitoral head and hood can shrink down as well. The urethra, which sits just underneath the clitoris, that changes. It changes its barrier to bacteria that come from the bowel. Even it doesn't matter how clean you're not, the bacteria will find its way into that little urethra, and the estrogen's necessary to help it, prevent that bacteria migrating. You've also got receptors on the base of the bladder. So as our hormone levels fall, all these tissues can start to shrink. They lose their blood supply gets less, and things can start to get uncomfortable. The main sort of things that women might feel is that they feel a bit itchy or sore. If they're trying to have intercourse, they may find it painful, even bleed, split. They may find that they can't orgasm, and it just doesn't feel right, So, and then they can get urinary tract infections, feel like they want to wee all the time, can't hold on to their wee. They get this, got the key in the door, and then they think, oh, I've got to pee, can't hold on. They may have other problems with coughing and sneezing and leaking. Now, a lot of women don't want to talk about this. They might ask their mum, and their mum says, oh, yes, that happens to everyone. Yeah. Older women think it's just part of getting older. You look in the supermarket, all those incontinence pads. It's kind of normalised that women will leak. No, let's not put up with this, because there are things that can be done to help. I would encourage women to look at themselves, get a mirror and have a look at what you look like. And if you notice anything that you're not comfortable with, if you think, oh, it's not, there's a white patch or there's an itchy patch or there's something that you think is strange, then you must go and see your doctor. Get used to what you look like, because then you'll notice if something changes. Yeah, don't be frightened.
That's a big thing, I suppose, for a lot of women. They don't know. It's very different for women. And so, like, some women don't even know the difference between a vulva and a vagina, let alone what you look like. So that there's such a lack of information on our own bodies.
Yes. Well, it's tucked away, so we don't really get to see it.
That's fair, which is fair. Yeah, you're right.
But there's lots of, if you look online, you can see lots of different images of what a vagina and vulva should look like. It comes in all different shapes and sizes, and nothing's wrong, but you need to know what yours looks like and see if there's any changes. And if you do start to feel uncomfortable, sore having sex, there are treatments for it. And I would say the sooner you get treatment, the better the outcome will be. Don't put up with it until your tissues are so sort of sore and tight, because it will take a long time for it to plump back up again. May not recover.
So could you talk about some of those treatments that are really helpful?
Yeah, the mainstay, is estrogen that you can use in your vagina and around the vulval area. It's body identical. It's estrogen, the same as we make, so it sits nicely on receptors. It comes either in a pessary or a cream, and you initially load the vagina, if you like, with a nightly dose for 2 weeks, and then twice a week thereafter. And usually within 3 months of that treatment, things should start to feel better. Less pain, less dryness, better sensation during intercourse. And if you have a really good response, obviously that will improve your desire to have sex, because no one wants to have sex if it's painful and if you're not going to reach climax or enjoy it. So often that alone can improve your sex life and also obviously your comfort. We also use this for women who are getting recurrent urinary tract infections, even if they're not sexually active, because it can reduce the incidence of urinary tract infections by improving the estrogen in the urethra, the outflow pipe of the bladder, and increasing that barrier to bacteria. So it's a very useful, simple treatment. Not much, if any at all, gets absorbed into the bloodstream, so you don't get any overbody effects from it. You can't use it at the moment if you've had a history of breast cancer, although having said that, it's always worth a conversation with your breast surgeon and oncologist, because a lot of them, if it's a very severe case of GSM, genital problems, they will say the risk is worth it, to improve quality of life. Because we don't want women who've had breast cancer, not be able to have sex. Not a great thing. You want that quality of life as well. So it's always worthwhile having a conversation with a patient's surgeon, and often I will do that if I have someone and say, look, I want you to try this, but I need to okay it with your specialist to make sure. And sometimes it is okay.
Yeah. And I'm assuming then, Dr. Sian, it's long-term usage of this particular medication. Is that correct? And so can you be any age to start this? So can you be 10 years post-menopause and start, or is it something that you need to start earlier?
No, you can. It's a better outcome if you start it earlier for the vaginal tissues. But yes, we use this in 90-year-olds, and if you start it in your, menopause, 40s, 50s, you can use it all the way through your life. Yeah, there's no need to stop it.
Right.
There's no need to be concerned about adverse outcomes. It's something that can be used ongoing. There's recently been a new kid on the block in this field called prasterone, which is a DHEA medication. I'm not even going to try and pronounce that word. I need to see it written down. But basically, it's a precursor for estrogen and testosterone. So once it hits the vulvovaginal tissues, it changes into estrogen and testosterone and sits on both receptors. So this is something that can be used if a woman doesn't respond to vaginal estrogen now, and can, improve sexual function, estrogenization of the vulval tissues, etc. The downside of this particular treatment is that it's a nightly treatment. You have to put it in every day. Now, sometimes that can be beneficial, because if you're like me and you can't remember to do stuff, if you have to do it every night, you'll remember, rather than twice a week. So, and it's not PBS listed, so there is a private prescription cost, which I think at the moment is about $45 a month. But it is in the armory, so it's nice to have options.
Yes. So are you finding that there are more treatments now becoming available for women for the treatment of certain symptoms?
Yes, they are slowly. This is an area that has been very dormant for a long time because of the problems with the WHI and the Women's Health Initiative that put women off taking hormone treatment. It kind of took menopause off conventional medicine's table, if you like, for a while. But I think there's more research and development in this area. I think what the government needs to do is to come on board with this and start, putting some PBS funding into it. Because, I think I heard recently that there hasn't been a new contraceptive pill, for instance, that has been listed for PBS subsidy for over 20 years. Yet we know that there are better pills that help women, that stop them having sexual dysfunction or mood swings, but you can't get them subsidised. So the people who need them often can't afford them. And very much so in this menopause space too. Prometrium, which we know is the best progesterone, it's the safest for women to use, you have to pay privately for. That's wrong. We're important. 51% of the population.
There is a high cost to being a woman, isn't there? Because all of those years where you've been menstruating, you're having to pay for every damn month for whatever you use during your period. Then when you reach this stage of life, and you may be on this medication now because I heard that there's been it's not just 5 or 10 years. It's now, is that correct? Am I correct in saying that now the hormone therapy that you can be on for the course of the course of your natural life, should you wish, is that?
Yeah. It's always a conversation and a risk benefit. After that first 5 years, it's important to see a GP, get all your health. You must stay up to date with all your screening, breast, cervix, if you've got one still, heart checks, etc. Your healthy checks. Are you drinking, smoking? All these things important. It's not just set and take it forever. You've got to stay in touch with GP.
That's right. And I suppose by having people like yourself coming on to talk to us about this, we can stay more in touch than just without getting information or knowing where to find it. So what advice would you give to women who might be embarrassed or hesitant to seek help for genitourinary symptoms? So what could they do if they want to see their doctor but they don't know how to approach it?
I think one of the things we are able to do in Australia is we can seek out a practitioner that we think will be someone who we can talk to. So if you think that these symptoms are due to your menopause, then you can look for the AMS site, the Australasian Menopause Society site. There are a list of GPs who are members, and you can actually make an appointment with one of those doctors and go and talk if you don't feel comfortable. If you have a male GP, maybe they have a female GP in the practice that you might feel more comfortable with. You can make that choice for yourself. I think a lot of patients feel they're being disloyal if they go and see another GP in their practice. I've had patients say that, what will he say if I come and see you? And I say, well, I'll just see you for this, and then you can go back and see them for other things. That's fine. Even if a patient wanted to come, or lady would like to come and see me and they've got a regular GP, I will write to their GP and say, this is what I think, this is what I would recommend. So we can all stay communicating with each other. So I think I'd say to a woman, don't be scared, find your voice. You're important and you can speak out to what you want. And if you don't get the advice that you are comfortable with, try again. Try again. I mean, I've had women who've been to see several doctors and ended up coming to see me because they haven't got the answer that they were looking for. And, sometimes having another fresh outlook can be really helpful.
Yes, it can. And talk to your friends. Sometimes a friend
Absolutely.
might have a great recommendation for you as well. That's another thing. But I will put a link in the show notes to the AMS site, a direct link, so that people can find it, because it's broken into various states. And there's even a section for those listeners who might be in New Zealand as well. There are a list of doctors who are in New Zealand also.
Yes.
I'm not sure if people were listening in other countries. Do the other menopause societies in other countries have a similar list where people can find doctors who may have an interest in
Yes,
this area?
I think most countries have their menopause societies. I know there's one in North America, there's one in the British Menopause Society. Yes, and they should be able to link you in with, doctors who have an interest focused on women's health. Yeah. And use your Google search. That's always helpful. To see, what am I feeling? Is this right? There'll be information on websites and other forums, women's forums. I think there are now women's, Facebook pages where women are discussing their menopause symptoms. So yes, use your friends, use your community, and keep knocking on doors. If you're not happy with the advice you're given, get a second opinion, third opinion.
Don't suffer. That's the thing. You don't want to suffer needlessly when there can be an easy way to help treat these sorts of symptoms.
Yes, absolutely. Going back to the genitourinary syndrome, obviously not everyone can use hormones. Those women who've had hormone sensitive cancers, what can they do? There's some really good vaginal moisturizers that you can buy. There's Silk, there's KY Warming. You want to find ones that are specifically vaginal lubricants. KY Jelly is too sticky. KY Warming is slippery because vaginal secretions are more slippery. So, try a few. Yeah. There's some evidence that laser therapy to the vagina, like you have, laser or ultrasound therapy to the face to plump the face. There are some machines that can plump the vulva and vagina. I don't think the evidence is out there to say who will benefit, how much benefit, how long it lasts, but it may be worthwhile just having a look online. I think one's called Mona Lisa Touch. There's a couple of others. It might be worth it if you want to try something like that.
Yeah. And just explore those options. So thank you. That's going to be really helpful. Now, we'll move on to the next topic. There was quite a lot of noise and pushback a few months ago about some people saying there was an over-medicalisation of menopause. Can you talk about this topic and what your views are and what the Australian Menopause Society says about that? Because, obviously you're informed by your organisation who you're a part of.
Yeah. I think when I heard this and saw this in the newspapers, I got a bit annoyed because I thought, here we go, we're shaming women again. Yeah. So finally, we've got women who are saying, okay, I have menopause symptoms. I want to do something about it. I want to feel better. And I'm going to go and see a doctor and I'm going to talk about this. And now they're being told, well, you shouldn't be getting these hormones. You're asking for things that you don't need. And this is part of life and you should just get on with it. So you're shaming women again. And I got quite annoyed about that because I think that we're not over-medicalising women. We're treating women appropriately. If we take the time, the medical we, take the time to take a proper history and listen to women and get all the information, if hormone therapy is going to be helpful to them, then we should be able to prescribe it without, fearing that we're creating a medical problem that isn't there, which is, just so not true. But I do agree with one aspect of it, which is don't hand out hormones thinking it's going to fix every woman's problem. Take a thorough history, take the time. And if you don't have the time, bring the woman back. Do it over a couple of appointments or make a longer appointment. Don't just say, okay, woman's sweating and a bit moody, have some hormones. Yeah, I think that's maybe what they were alluding to, that maybe GPs are just giving hormones too readily. I don't think so. I think we're very cautious. I think we're good at what we do. But yeah, get women to, find a GP who's willing to talk to them and spend time.
Well, with 51% of the population being women, 80% of women who may be experiencing some sort of moderate to mild symptoms, even to those who are, so that percentage that experience really extreme symptoms.
Yes. Yeah, exactly. And when you look at
reflected in the amount of uptake on hormone therapy that's being prescribed anyway, is it? So
I think we're still quite low. We're still quite low in the prescribing of hormone therapy. I think maybe, I don't know where it came from. And I know the AMS is very clear of this as well. Doctors are not over-medicalising menopause, but we do need to make sure we take a thorough history. We do our jobs to the best of our capability and spend the time taking the history and examining women and getting all the facts and prescribing appropriately. And, if we don't have the time, we need to be able to be allowed to give women the time, which comes back to what you were saying about the cost of women's health on the woman, is that inequality in health, which I think you had someone on your podcast talking about, is that women have to pay for this service. They have to pay to see doctors to get the right advice. And, the Medicare until very recently was very poor at rebating women for these complex needs. I mean, there are new item numbers coming through Medicare that will allow doctors to spend more time. But we have to be able to carve that time out in our busy practice lives. Yeah. So there's only, a number of women who want to focus and do that. And it's finding them if you need. Yeah. I hope that answers that.
And there was a recent Senate inquiry as well into menopause and what could be done in this space. So it'll be interesting to see what comes out of that and the findings and recommendations.
Yes, there needs to be more. I think the UK Dr. Louise Newson actually presented to our Senate, and basically it has to start in the training of doctors. We need to train our new doctors in this field. I mean, I don't remember having any training in menopause treatment. I mean, we learnt about it. We learnt that it happened and all the things that could happen, but we weren't given an awful lot of information about how to manage it. So it's the education of the younger doctors, of the gynecologists, of the GPs in their training, so that we know about as much about this as we do about diabetes or heart disease. Or it's as important.
Yes.
It's not a, it's a serious medical issue, really, for a lot of women, not all women, just about sort of 80%, and these genital problems that women can get, it can be progressive, and this is women who are, can become incontinent in their older years that you might have been able to prevent. These are women who are, with hormone therapy, who can end up with fractures in nursing homes that we could have prevented.
The long-term care and costs on the society anyway, isn't it? So to manage it well earlier only makes sense.
Absolutely. And if you're looking at managing menopause symptoms, the impact it has on society, on marriage breakdowns, on loss of women to workforce, the problems women can experience parenting when they're going through severe mood disturbances through hormone fluctuations. It's not a small issue, and women shouldn't feel that it's a small issue and made to feel shame that we're over medicalizing it. Would we say that if someone had diabetes? Oh, we're over medicalizing your diabetes? No. So can we not use that kind of language when we're talking about women's health?
It's super confusing for women as well, because we've got so much more information out that we can access now, even compared to 5 years ago.
Yes.
But there's a lot of misinformation as well. There's a lot of people who are trying to make money out of this, offering various supplements that are not well researched, that could have anything in there, not evidence-based. So it's really quite confusing for a lot of women. So the Australian Menopause Society is a great place to start. And again, as I said, that'll be in the show notes.
Jean Hale's are
Jean
very
House
good
for
as
Women's
well.
Health. Yes, that's another one
Jean,
that I often
very
recommend.
good.
Yes.
Yeah.
Yeah.
And I think, yes, we need to, like you're doing, and other, like Louise Newson in the UK, which you can follow on our Instagram here now. You can get onto a Balance app from here. There are people who are really working hard to get good, solid information out to women. But you do need a GP to prescribe.
Yes.
So you need to have that conversation with a medical practitioner who needs to be able to work with you and change things as you say. You've got to be able to find someone who you can come back to and say, well, that didn't work. Can we try again?
Yes.
Yeah.
Yeah.
So you have to build a rapport and a relationship with that person. And that person can work with your GP as well. You don't have to jump ship completely. Yeah.
Yep.
So,
no, sorry, you continue.
no, I think I'd run out of steam.
I thought you were just about, I thought you had finished before I said now. Well, I have some questions that a number of ladies want answers to. But Dr. Sian, there were a lot of questions. And we've talked at length now on a lot of different topics. So I don't want to make this a super, super long episode. Would you be willing to come back? If we just answer a couple now, to come back at another time to answer some of these questions that women would like?
If I can, I will. Yes,
definitely.
definitely.
That would be brilliant.
I'd love to come back, but
right.
Yeah, I hope I can answer the questions. But
well, if you can't, well, then perhaps we'll look into it. And again, I just want to make sure that everyone understands that you're going to be answering the questions that I'm going to ask you now, and hopefully in another future episode, as general advice only, because you haven't sat down with that particular woman to get all of that background, that important background information. So
great.
Chat further, it might be a great opportunity to get some basic information to take to your own doctor to then, have that further conversation.
Have that conversation. Yeah.
Okay, so the first one is from Judy. And Judy asks, could my meds of thyroxine and Pristiq, I'm not sure if I've pronounced it correctly, be causing me to have sweats and flushes?
Absolutely. Yes. The thyroxine obviously needs monitoring. Your dose of thyroxine, you need to have blood tests to make sure that you're in what we call a therapeutic range. And that range can reach a steady state quite nicely, and you only need to have a blood test, once a year. But if you're getting symptoms like sweating or changing your appetite or changing your weight, then yes, you should request to have your thyroid levels checked again. Yes, and you can go to your GP and ask about that. Medications like Pristiq, that family of medications, can have as a side effect sweating, especially as doses are increased. So if you've had a change in your dosage of your medication, you may start to experience more sweating. So it's always worthwhile when you have a new symptom, even if it does correlate at a time where you could be getting vasomotor symptoms from menopause or sweating from menopause, to ask these questions about other things that could be going on, like your Pristiq or your thyroxine. So yes, you're quite right, Judy, it could be either of those. So go and have a chat with your GP. Yeah.
Right. Sally asks, and this is something that was covered in an interview that I had with Professor Anne McGregor, but what is an alternative to HRT? Patches and tablets gives me migraines.
Okay, so this is not an easy one to give a stock answer to. Migraines in themselves need to be addressed well when you're looking at menopause. Yeah, how your migraines are being managed is really important. People who have bad migraines that are associated with aura, flashing lights, etc., or get frequent migraines, need to use the body identical estradiol through the skin. Tablets they should not be taking because of the possible increased risk of having a blood clot stroke. So I would urge you primarily to get those migraines sorted out, and that may require you to see a headache specialist, a neurologist. Yeah, and then you may find that you would be able to tolerate the estrogen a lot better. If not, or for some reason you can't use the estrogen because the migraines can't be controlled, which I doubt, there's always something that can be done with migraines, and we're getting much better, the medical getting much better at managing migraines. Definitely worth another conversation. It's one of those areas not all GPs have all the information about. So if you find that your GP is not well versed in this area of migraines and headaches, there are a number of neurologists that specialize in this area who are absolutely excellent. You can also get information from migraine sites, associations that will tell you what the up-to-date management of migraines is. But there are non-hormonal managed treatments for various menopause symptoms. Depends on what your symptoms are as to what sort of treatment you would be offered. So if you're looking at, is your worst symptom and what you want to get rid of your night sweats and hot flushes, there are particular medications that are non-hormonal that you can be prescribed for that. If you want to have a look at which ones, go to the Australasian Menopause Society. They will list the alternatives to hormones for those symptoms. Similarly, for mood disturbance. Yeah, the genital symptoms, you should be able to tolerate the genital, vaginal, because not much gets into your system. So I think it would be very unlikely that they would trigger your migraines. Yeah. So I think what I'd recommend for you, Sally, is go back and have a conversation with your GP again around this and say, okay, I shouldn't be taking the tablets, the patches, look at what's in your patch. Is it estradiol? What's the progesterone that you're using? Is it the right, body identical progesterone? And really, have a better conversation about your migraine management.
Excellent. Thank you.
Yeah.
Next question from Ashley. If you have severe endometriosis, how does this affect your menopause journey?
With endometriosis, this is a tricky one for you because I'm assuming you haven't had a hysterectomy. So, or even if you have, you shouldn't just have estrogen, you should have progesterone if you've had a hysterectomy for your endometriosis, because it's one of those areas that's not fully investigated. We don't know for sure, but we think that if we gave a woman who'd had a hysterectomy just estrogen and not progesterone, they would get endometrial deposits flaring up again. Yeah. So the guidelines at the moment are if you have had endometriosis and a hysterectomy, you should have estrogen and progesterone. For you, if you've still got your uterus and you are still getting endometrial pain, you would be someone that would need to collaborate with a gynecologist and a GP to help you through your menopause journey. Because what we don't want to do is flare up your pain because of what we're giving you hormone-wise. So you would be someone, if you came to me, I would be saying, I need a gynecologist to help us manage this for you so we don't make things worse.
Yeah. I do know the background from Ashley because she has messaged me before. She has had a hysterectomy.
Yeah. So yeah, the information that I recently have had to look up for a patient who came to see me was yes, progesterone is recommended with estrogen even though you don't have a uterus. The evidence isn't 100%, but I think it's better than than taking the risk of just giving you estrogen and making things worse for you. Right. Down the track, we may get that information through from the lovely people who are doing these studies to say we don't need to give you progesterone, but it certainly won't be doing you any harm. So I think that would probably be what you would need to do. But I would urge you to, have a collaborative appointment, your GP and your gynecologist to really work out what's best for you. Yeah.
Mm-hmm. There was one also from Gillian. Now, Gillian just had DHEA with a whole lot of question marks. You did mention DHEA before, as in I'm assuming that she'd like to hear more about how DHEA can be used to treat menopausal symptoms. Now, you did mention, recalling that you mentioned it to treat the GSM symptoms.
Yes, and that's the only evidence there is for using a DHEA in menopause management. Is that prasterone, which is a synthetic DHEA-like substance. Information recently from Sue Davis, who's doing a lot of the research at Monash, is that there is no place for DHEA in management of menopause symptoms. There's no evidence that it actually is beneficial. So yeah, it's not safer than hormone treatment, it's not better than, and it probably doesn't do more than placebo. So she was quite adamant that there isn't a role for DHEA, and she's, as you know, has been working in this field and doing significant research. She's one of the main collaborators in the recent position statement on use of testosterone. It was an international thing. So she's up there. We've got a good one in our ranks.
We do. We've got somebody in our court looking after us. Well done.
Yes. So, also, the use of DHEA is often in compounded, what has been previously and often confuses us, bioidentical, which was a whole industry that popped up when women were scared of conventional hormone treatment. So compounded is not recommended either because of the problems with manufacturing and bioavailability of the medications. So yeah, the short story on DHEA is it's not useful, doesn't work.
Brilliant. Now, Shari asks, how long would you notice for an overall improvement after taking HRT? And in brackets, she had gel progesterone tablets.
Everyone's different because I'm going to assume that she's having transdermal estradiol.
I assumed so because gel. So
everyone absorbs estrogen differently through their skin, but you can get improvement in symptoms within a couple of weeks. Vasomotor symptoms and joint pains can be, some of the quickest to respond.
Yeah, was for me.
Estrogen. Yeah, mood can take a bit longer. Can take 2 to 3 months. So what I usually do is see a woman in a month, see how they're getting on. But the peak effect is at 3 months. So I usually see it 1, 3. And then depending on how they're going, 6 months, maybe then after a year. So yeah, you should notice some improvement. What is interesting though is, and this is what I found when you really get to spend time with women and see them and follow them up, is often if that joint pain doesn't go, there's something else going on. There's some underlying autoimmune problem, osteoarthritis. So, it's so important to follow up on all of these symptoms, not just 1 or 2. Someone can come in and say, I feel great, my hot flushes have gone and I'm feeling so much better. And you go, well, how about that joint pain that you were giving a score of 3? Oh no, that's still there. And you go, oh, okay, well, it shouldn't be. So let's dig a bit deeper into this. So that's why it's so important to get that rapport with whoever's helping you.
Yes. Yeah. Final one for today then. Sharon asks, if I don't live nearby, can you do a consultation via Zoom?
Soon. The problem I can. The problem for you is that Medicare won't let you get a rebate, because unless you're seeing your usual doctor within 12 months of a telehealth appointment, you won't get a rebate from Medicare. So that's their rules, not mine. But yes, that is a possibility. And I am, as I've mentioned to you, Joe, wanting to do more women's health and provide that service. And I think when this podcast is available, there will be some links to see if you can do a telehealth with me. Yeah. Telehealth has its limitations. You can't examine you through a telehealth consultation, but at least we can have a conversation, which might be helpful and maybe lead you to see someone if you do need to have those examinations done. Yeah.
Brilliant. Now, all of the direct links to everything that we've mentioned will be in the show notes, so direct links to you when you're, as you just said, by the time this podcast is released, you'll be in your new practice and website, Insta links. They'll all be there for people to be able to have a look at and download. But to wrap up, I've just got 2 quick questions for you, Dr. Sian. What are you most enjoying about this stage of life?
Most enjoying is embracing my curiosity for life, because my children have left home and I have that freedom to, suit myself now, to be able to, if I feel like doing something, I can do it and I can enjoy this wonderful planet that we have and, look at things in a different way than I did when I was a full-time parent and, a full-time GP and, single parent, when you were just too exhausted to stick your head above the parapet. And the other thing I'm really enjoying is being able to spend more time in this field, in women's health, menopause management. It is the most interesting, rewarding. It's at the frontier of medicine. I feel passionate about it and very privileged to meet the women who, place their trust in me and come and seek me out and allow me to be involved in what is and will be the best times of their life, I'm sure, too.
That's lovely to hear. How wonderful that you were on the podcast with us today. I've got a final wrap-up question, but I just want to thank you so much. It's been incredibly informative. You're a mine of information and you just so freely share it all. So thank you so much for coming on.
You're welcome, Jo. I was a bit nervous, but you're so welcoming and so easy to talk to. It's like having a chat, in my own front room with a small glass of wine.
A little thimbleful. All right, and our final wrap-up question, Sian, is what do you hope 80-year-old Sian is going to say about current day Sian?
Good on you, girl.
Love it. Love it. She'll be very proud. Yeah, that's brilliant. That's brilliant. Thanks so much, Sian. And again, I hope we can have you back on to the podcast to answer some of those other questions that we didn't get done today. But thank you so much for your time.
Thank you, Jo.
Thanks so much for listening and sharing your time with me today. I'd love you to hit subscribe on Apple Podcast or your favorite podcast app to keep spreading these empowering messages. Please share this podcast with other incredible midlife women in your world. Join me again next week for another redefining midlife conversation. Thanks again for tuning in.